This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Eris, a senior attending in neurosurgery.
And I'm Dr. Alara, a research fellow. Today we're looking at a fascinating new study from the Journal of Neuro-Oncology, published in 2026. The paper is titled Fractionated Stereotactic Radiotherapy, fSRT, for symptomatic WHO Grade 1 Cavernous Sinus Meningiomas, Long-Term Local Control, Clinical Response, and Toxicity Outcomes by Ryan Shaw and colleagues at Thomas Jefferson University.
This is a topic that hits home for anyone who spends time in the skull base suite. Cavernous sinus meningiomas, or CSMs, are notoriously difficult. We're dealing with some of the most expensive real estate in the brain, the internal carotid artery and cranial nerves 3 through 6. Ilara, before we dive into the data, remind our listeners why the cavernous sinus is such a surgical no man's land.
Exactly, Dr. Eris. As the authors point out, while these are usually benign WHO Grade 1 tumors, their location makes maximal safe resection a massive challenge. The paper notes that gross total resection rates vary wildly in the literature, anywhere from 12% to 80%, and the risk of postoperative cranial neuropathy is a major deterrent. That's why radiation therapy, either as an adjunct or a primary treatment, is so critical.
Right. And we often debate between stereotactic radiosurgery, SRS, and fractionated stereotactic radiotherapy, fSRT. What was the rationale for focusing on the fractionated approach in this study?
The authors highlight that while SRS is great for small tumors, the risk of toxicity increases significantly when the tumor volume exceeds 10 cubic centimeters, or when it's abutting sensitive structures like the optic apparatus. They cited a statistic that permanent complication rates for SRS in tumors over 10 cc can reach 21%. fSRT, typically delivered at 1.8 to 2 gray per fraction, allows for a more favorable toxicity profile by taking advantage of the 4 R's of radiobiology, specifically repair and reoxygenation.
So this study looked at a retrospective cohort from a single institution. Give us the breakdown of the patient population.
They followed 39 patients treated between 2006 and 2017. The median age was 60, and the median Karnofsky performance score was 90, so these were relatively high-functioning patients at baseline. The median tumor volume was exactly 10 cc, ranging from about 3.6 to 18 cc.
10 cc is a very relevant size for our listeners. It's right on that threshold where we start worrying about single-dose radiosurgery. What was the treatment protocol?
They used a standard fractionation scheme, 1.8 to 2 gray per fraction, for a total dose of 50 to 54 gray over 25 to 30 fractions. But the real strength of this paper is the follow-up duration. The median follow-up was 122.2 months. That's over 10 years of data. In the world of grade 1 meningiomas, you really need that decade of follow-up to see the true story.
Absolutely. A 5-year follow-up in meningioma research can be misleading because these tumors grow so slowly. So after 10 years, how did these patients do in terms of local control?
The results were quite impressive. Local control at 1 year was 100%. At 3 years, it was 94.6%. At 5 years, it stayed high at 91.7%. And even at the 10-year mark, the local control rate was 88.1%.
That's very stable. For a resident or a student listening, local control usually means the tumor didn't grow on imaging. But as we know, the patient cares more about their symptoms. Did their double vision or facial numbness actually get better?
That's perhaps the most encouraging part of the study. 2/3 of the patients, 66.7%, showed clinical improvement after fSRT. About 23% remained stable, and only about 10% experienced any worsening of symptoms. This is significant because it suggests that fSRT isn't just freezing the tumor in time, it's actually allowing for some neurological recovery.
That 66% improvement rate is a great talking point when consenting a patient. If they have a pre-existing cranial nerve deficit, you can tell them there's a good chance of improvement, not just stabilization. Did the paper go into detail about which symptoms improved?
They focused on symptoms attributable to the cavernous sinus, so diplopia, ophthalmoplegia, and trigeminal distribution sensory changes. While surgery has a wide range of reported recovery rates for these neuropathies, 14 to 67%, the fSRT data here sits comfortably at the top end of that range without the immediate surgical risks.
And what about the downside? Did they report on long-term toxicities?
Toxicity was minimal. Because of the fractionation, they were able to spare the critical structures. The authors concluded that fSRT provides an effective approach for these larger tumors with a superior complication profile compared to historical SRS data for similar volumes.
Let's summarize the take-home for the practicing neurosurgeon. When you see a patient with a symptomatic grade 1 cavernous sinus meningioma, especially if it's approaching that 10 cc mark or wrapping around the carotid,
The take-home is that fSRT is a highly durable option. With an 88% local control rate at 10 years and a 67% chance of symptom improvement, it challenges the idea that we need to be overly aggressive with surgery in the cavernous sinus. The authors do suggest that larger prospective studies are needed to validate this, but a 10-year retrospective analysis is a strong starting point.
It really highlights the shift toward functional preservation in skull base surgery. We aren't just looking at the post-op MRI, we're looking at the patient's quality of life 10 years down the road.
Exactly. It's about balancing the biology of the tumor with the anatomy of the patient.
Well, that's a great overview of the Shah et al. Paper. It's a solid piece of evidence for the multidisciplinary management of these complex lesions.
Thanks for the discussion, Dr. Aris.
Thank you, Alara. To our listeners, if you found this summary helpful, would you like a summary of the next chapter in this series of skull-based studies?